Um, so we'll start now, yeah? No, he's not. He's on the phone call. Yeah. Okay. So, Assalamu alaikum, everyone. I just want to start quickly with a brief introduction. So, who the team is, what we're going to discuss, and then we'll take it from there. So, my name is Sabir Gulam. I am the relationship manager for the account. I started the conversation a while back. I will be overseeing the entire account, and I'm representing LifeCare International, which is the broker that is managing the account. My colleague with the blue shirt, his name is Joseph. He will be assisting me in managing the policy in terms of when I'm not around or if I'm in a meeting or something. If I can't be accessed, he will be accessed. After the meeting also, we will share a contact list of about 3 more people who will be handling the day-to-day administrations, authorizations, everything from the broker point. The gentleman standing, his name is Dennis. He represents All Mutual directly. So what he's going to do is he's going to take us through the product, the process, the turnaround times, and then we will be able to answer any questions that you might have regarding the product and how it works.
Thank you so much, Sabir, for those brief remarks and introduction. As stated by Sabir, my name is Dennis Webola. I work at All Mutual as a relationship manager. So basically, with Sabir and Joseph, we deal with the day-to-day administration of these schemes. Where there are any questions, where there are any queries, if a person happens to get stuck, then we are the right people to reach out to. Also, in case of any clarification, we'll be able to handle all of that. So maybe just to begin, I'd like to take you through a regional presence where the insurance cover works. As shown on the screen, the beauty about this particular insurance product is that if you are in any of the 5 aforementioned countries, that is Kenya, South Sudan, Uganda, Rwanda, and Tanzania, you are able to enjoy a seamless service as you will have here in Kenya. That is through your either mobile smart apps or your plastic cards for those who have. You can go to any hospital facilities within our panel and start your medical treatment. So who are the eligible members is first of all you by being members of the community, plus either your dependent, that is your spouse, and the principal member. So joining the scheme is voluntary through the office, management office, whereby they will issue us with an email notification stating that a particular member wants to join, and we'll get the particulars of that particular member, the name, phone number, email address for the purposes of onboarding on the smart application scheme. Leaving the scheme again is voluntary upon a member willingly exiting the community or being deceased. So basically, this is the scope of how the insurance is structured, whereby we have 2 main categories. Category A for those with an inpatient limit of 3 million, and Category B for those with an inpatient limit of 100,000. We also have outpatient, again defined by the categories. We have 150,000 for members under Category A, and 100,000 for members under Category B. And the beauty of this particular structure is that it's per person. So it's 1 person, 3 million, 1 person, 3 million, or 1 person, 1 million, again depending on the category which they are.
Sorry, so while he's presenting, if you guys don't mind, I will jump in and share some salient points of what I feel you should know about that particular point. So you can choose the category that you want from the point of renewal. You can choose the category that you want from point of renewal. What maybe you already know is after the renewal period, they give you about 2 weeks to make a decision on the benefits that you want. But if that 2 weeks passes and you go into 2 months or 3 months, you can't change the category you're in between the policy. That can only happen once at point of renewal. So that's, I feel, is an important clarification to share.
Okay, thank you for that clarification, Sabir. Now I'll take you through the skeleton of this particular insurance product, and I think this is where members should at least pay keen attention to. To start us off, I'll start with the overall limit. As I had stated, there is members under 3 million and those under 1 million. So what is covered under this particular umbrella or skeleton or structure is that we have a sub-limit or a benefit of bed. And for members under category A, they are entitled to standard private room up to a limit of 18,000 per day. While those under category B, they're also entitled to standard private room up to a limit of 16,000 per day. Lodger fee is also a benefit, but for this organization, I doubt if it exists because it's basically for children below the age of 12 years. While the organization population doesn't allow that, so this particular benefit, while it appears, it's not applicable for the community. For emergency evacuation within East Africa, we are also entitled to road ambulance. For any acute illnesses and accidents, you are covered up to your full inpatient limit, depending again with the category, either 3 million or 1 million. For a pre-existing condition, this basically is a condition which you had prior to joining the insurance coverage. Then treating that particular condition will be covered up to a maximum of 700,000 for category A, while for category B, it would be covered up to 400,000. Just to give a brief description of what a pre-existing condition is, a pre-existing condition is a condition which you have been treating for a period of 3 months and more. So upon joining an insurance cover while you are still getting that treatment, it will be turned into or categorized as a pre-existing condition. While the opposite for that is a newly diagnosed condition. And in this instance, you are covered up to a limit of 2 million for category A and 700,000 for category B. So you happen to be in the scheme, and let's say you are diagnosed with cancer, then those will be the applicable limits for that particular condition. Also, there is a benefit for organ transplant in the event that you are admitted in a hospital and there is a maybe kidney transplant, then that is also covered. Again, depending with the sub-limit, it could be either a chronic condition pertaining to that particular organ transplant or a pre-existing. If it's a chronic, then the chronic limits of 2 million or 700,000 will apply. If it's a pre-existing, then those will be the applicable limits. Yeah, kindly. Yes, kindly.
I have a question on existing, because you say in category A, that's the 3 million cover, the existing is 700,000.
Yes.
Correct?
Yes, correct.
And newly, God forbid, newly diagnosed is 2 million.
Yes.
I don't understand this. What happens? I am a diabetic.
Mm-hmm.
I'm a diabetic. Then, and mine is a pre-existing condition. So why should I only be covered for 700,000 when my policy is 3 million?
Do you want to take that?
Yeah, you can take it.
So, Assalamu alaikum, Uncle. So, first let me clarify 2 things. There is 2 situations where you were diabetic when you joined the scheme. That's a pre-existing. Then there is another situation where you join the scheme and then you become diabetic while you've joined the scheme. So what they're saying is when you become diabetic, once you've joined the scheme, they'll give you 2 million shillings to manage that chronic. If you've come in with a pre-existing condition, they will give you 700,000. It's not that the scheme is designed that way. It's all local underwriters always put a cap on pre-existing conditions. They would never be in a position where they give you 3 million for the entire pre-existing condition.
For 3 million,
Yes,
you are saying 2 million
correct.
if newly diagnosed.
Yes, correct.
So I am being deprived then. In my case, I'm telling you, in my case, I'm a
Yeah.
diabetic.
You're right.
Yeah. God forbid if I fell sick, okay, and I am hospitalized. So you have already chopped me off. You're only giving me 700,000, whilst my cover is 3 million. And you're offering the same thing to 2 million to somebody who is,
Newly diagnosed.
yes.
Yes.
It doesn't make sense.
It gets a bit more technical than that. You see, when you come on the cover with a pre-existing condition, it means the probability of you claiming is higher than somebody who doesn't have a pre-existing condition,
Absolutely.
right?
Yes.
So the risk calculation behind it is very different. So that's why they have capped the pre-existing condition, because 9 out of 10 times you will claim for that diabetes, right? Somebody who doesn't have diabetes and is diagnosed later, there's still a 50-50 probability. So that's the logic and the way they underwrite the policy. I agree. I agree with you. I agree with you, but that's unfortunately how local underwriters. Hmm.
God forbid if something happens to me, you will only pay me 700.
Yeah.
My God, if my bill runs to 1 million and above, then where am I going to get that money from?
So there is something else we can do. Maybe not this year, but next year we can look at renegotiating the. So unfortunately, Uncle, that's the way the product has been designed, right? And that's how the benefits have been structured. Because put it in perspective, yeah? Let's say you fall ill, but it's not diabetes. Inshallah, you don't fall ill. But you fall ill and it's not diabetes and it's something else. They will cover for the whole limit, right? So you have to look at it at the pros and the cons of it. Yeah.
I agree, but you have to understand.
Yes.
You are in this business, you know.
Yes.
the diabetic.
Yes.
They are going to look for reasons.
Hmm.
I mean,
And that's where Life Care now comes in, right? To make sure that, yes, no offense, but to make sure that they don't take advantage of the situation too much, because we understand the business. We've been in the business for 30 years, so that's where we come in to provide value.
but my friend, it's already taken advantage.
Okay, so,
My scenario, it's already taken.
yeah.
I
So-
think basically just to answer Isma, come next year we can have a review of the old structure and
God forbid, I feel sick now. Do I wait for the sickness to come next year?
No, you can't. You can't do that. But you see, for the purpose of time, Uncle, if that's okay with you, can I come and see you one-on-one after the presentation and we discuss it? Thank you. You seem to have another question. A similar question.
Assalamu alaikum.
Walaikum salam.
I have a similar question on Iqbal Uncle's line. You're dealing with an age group that is elderly. So there is one or the other pre-existing conditions that we will have. Let me put myself.
All right.
One of them could be high blood pressure.
Correct.
Now, when you say the 700,000 covers pre-existing conditions, and if I have high blood pressure, does it only treat high blood pressure? Because high blood pressure could lead to other things, like a stroke, a heart attack. And that is now, will you say because of your high blood pressure, it led to this, so, but we're only giving you 700,000 because of that. I think it's very similar to what Iqbal
Yeah.
Uncle has just mentioned.
So I am so glad you asked that question, because that's one of the points that I wanted to clarify. Now, there is no black and white answer to such a question, all right? The key important thing I will tell you is it all depends on the way your treating doctor gives the information. If he gives the information that, say, for example, you're a hypertensive, and hypertension maybe 7 out of 10 times leads to a heart condition. Heart condition could lead to a heart attack. If he indicates that your heart attack was caused by a series or your treatment towards the hypertension, then all of that line falls under the pre-existing. However, if he indicates that the heart attack or any other condition that has developed has no correlation medically from the hypertension, then it falls under a different category of benefits. I don't know if I'm answering that clearly.
Yes, you have, but you see, insurance companies.
Yeah, I know
I'm
what
not gonna
you
go
mean. Yeah.
Further than that, I have a question. I'll have a question later on
Yeah.
with my experience. So I just wanted to clarify some things. But you know, insurance companies don't say things in black and white. There's always gray areas. There's always how to get out of it.
Yeah.
You just mentioned 7 out of 10. So that's a 70% probability. How do you now protect, or how do you do that 30%? You know, a doctor.
You need to be informed at the time of the admission, at the time of where you're going through the treatment. Whoever is with you, make sure they control the information that goes out. We have personally seen in many experiences, it's not the client's fault, it's not UAP's fault, it's not the broker's fault. The doctor writes the wrong diagnosis, or they write the information wrongly because they're in a rush. So my advice to that is, when you're hospitalized and you have somebody with you, just make sure that the information is clearly indicated and is well controlled by the family member that's with you. That, in my opinion, is how you control the 30%.
Because basically once we get the report from the doctors, that's
It's
it from our end.
Yeah. Once
We'll act
any
on it.
underwriter gets a report from the doctor, whether the doctor made a mistake, whether they wrote the wrong thing, it's almost, I would say, next to impossible to reverse it. Because it's going to be another doctor to give a second opinion. Then there'll be an argument after that. Then there'll be a different opinion that comes from the member themselves of the series of events. So that's why it's so important that you control the information from the get-go.
So are you saying that we don't say the truth?
No, I am saying, I'm not saying that you don't say the truth.
Because the doctor will ask, am I on any medication?
Correct.
And if you are on medication, it is whatever it is, if it's a blood pressure medicine or whatever, you know what they will say. Oh yeah.
Yeah.
So they try, and that's very difficult, because at that moment there's a lot of things happening, and you want to give the right information to doctors so that when they're treating, they know what medication. If you don't say the truth, then you also may be getting into a lot of.
So,
or you just don't say a lie.
I see what
I'm
you're
just
trying to do.
I'm just trying to.
No, but the point is, I'm not saying don't give the information. I am saying that make sure that the information is going to the underwriter is properly depicted. We are dealing with cases right now where the member has not indicated when the condition has started, what is going on, right? And the doctor says, I have treated him for diabetes. It doesn't say when the diabetes started, or the diabetes, are they treating only the diabetes, or they're treating something else coming from the diabetes. So I'm not saying misinform. I'm saying just make sure the information is clear enough. The other alternative is, I can sense that the pre-existing limit is quite a big concern to the community, right? Now, there's two things we can do. We can go back and review this, okay, if you guys want. Change the limits, but it has an impact on the premium. Yeah. It will definitely have an impact on the premium, Because if we move that up, if it goes to 1 million, let's say, or you say, let's say, give me 50% of the 3 million to cover pre-existing, it will have the impact on the pricing because it is going to be claimed to that limit.
But you just mentioned
Yes,
that I can request 50% of my cover.
yes,
So if I have a cover of 3 million,
yes.
I can ask you cover me up to 1.5 with anything to do with diabetes or heart attack.
We can't do it for one person. It has to be structured for the whole community. Yes. It can be done, but again,
But without touching the premium.
that's not possible. That's not possible. Continue.
On the same topic, huh?
Yeah.
I would like an assurance from the new scheme. If I may ask you, I know none of you are medical experts here, but I'm sure in your time you know. Pneumonia has got any relationship with Parkinson's disease? There's somewhere I'm going with it, huh?
I'm not a qualified doctor to
But-
answer that
but
question,
I-
but
from
from a
your
layman
experience.
point of view, very unique cases does it lead to Parkinson's
Very unique
disease.
cases.
Yes.
In the past, it's been known that, I'm sorry to say,
Yes.
that the hospital and insurance companies are colluding in this thing.
Okay.
Okay, I have a very recent case
Right.
where pneumonia was tracked back to Parkinson's disease and went into a pre-existing because my late dad had mentioned that he had Parkinson's.
Yes.
Okay, and when he got pneumonia, on a 6th day in the hospital came and said the insurance has said that we have to check you out because this is a pre-existing condition and your limit is over.
Okay.
Think about it, between pneumonia and Parkinson's. 1 out of 1 million would say it's related.
Correct.
So what is happening is pneumonia could be 1 in 1 million chance, probably caused by Parkinson's.
Correct.
But the insurance is going to jump to the case that only the doctor indicates that it could have come from Parkinson's,
Yeah.
and it's immediately picked as a pre-existing. How can you help us? Because
So now I am going to give you some information on how, so as Life Care, we deal with 2 sets of types of policies. We deal with international policies, so I'm sure most of you, the likes of Bupa and all of them, you know them, and then we deal with local policies. These 2 underwriters operate extremely differently, and I'm not saying that UAP is not good, but the rules behind each one works differently. So I'll give you how we normally use it from IPMI, from international, and how we use that information on local. With international, if something like that happens, we have something that is triggered called a second medical opinion. So we get another doctor to come and review the case. The other doctor has no correlation or has no, for a lack of better words, incentive to misinform because he's not involved. He's not making money from the patient, he's not working with the insurance. So they give a particularly different second medical opinion. If that medical opinion differs from what the doctor is saying, and he's saying that, look, yes, it might be a possibility, but based on this case, we feel this, this, and this, that it's not related. Bupa then, an international provider would open up the case and ask the member that we have 2 options. One is we can get you another doctor to come and see this case, and you start again. 2 is we make an exception. But these are unique cases. Let me please emphasize and underline that word. Very unique cases. That they would come back and say, fine, this is the situation. We are willing to extend you up to this much. That your limit was this much. We will push it up to this much. That's how we normally treat such scenarios. Now, we use kind of that same technique with local underwriters. But of course, it works differently with local. So, just to take exactly your example, we would involve another doctor, which we have in-house. They would evaluate the situation. They would give their their medical opinion. We will then share that with UAP to review. And then we would fight it once, twice, 3 times, right? But the thing, sir, that we cannot control is the final decision is always the underwriters, right? So what we try and do is give as much information to fight on your behalf, and that's how we normally operate. So there's no clear cut, yes, they will push it from 700 to 1.5 million. It depends on the case, it depends on the information you put out there, and how you justify on behalf of the client. Yes.
Work with local underwriters.
Yes.
The success rate, because I've also had experiences like this. Have you ever been able to change the limit with local underwriters? 'Cause
Exceptions.
I've never heard of it.
Okay, what normally happens with us, the local underwriters, is that we have a provision known as the ex gratia basis. Once it usually compromises a committee within the organization of medical doctors, clinicians, pharmacists, and care nurses who sit down and analyze the report. Based on the severity of the case and the uniqueness, as Sabir has stated, then we can pay up to the difference of which was supposed to be paid by the hospital or by the member and reimburse it to the client. So it usually happens, and the success rates, again, depending with the circumstances of the case.
So we have seen, to answer your question, we have seen it happen, not with 1 or 2 underwriters. We have seen it happen. Like I said, it's a rare case. There's a lot of data and justification that goes behind it, but to answer your question with sincerity, it does happen. Rarely, but it does happen.
Okay, thank you. Okay.
Yeah.
Assalamu alaikum.
Wa alaikum salam.
See, I'm a diabetic patient. Acha, now, if I have got a heart problem, God forbids, and I go to cardiologist, right? Now he suggests me for angiography. Well, let's see how much it is blocked or something like that. So what about the angiography? If I'm admitted, and then they go for angiography and say that okay, you have to have one stent, then how we are covered with that, for that?
So before I answer that question, Uncle, did you have the heart condition before you joined the
No.
scheme? So it's covered under the new chronic
Okay.
condition limit. So they will give you the stent, they
Yeah.
will allow the angiography,
Uh-huh.
and then they will give you up to a limit of 2 million.
2 million.
Yeah.
Okay.
But it's on the premises that when you went in,
Hmm.
you were only diabetic. The heart condition developed after you joined the policy.
After I joined.
After you joined. Yeah.
Okay.
So that's how it normally works. So it falls under the routine, the chronic condition benefit.
Okay.
Because heart will become chronic, you'll manage it again for the rest of your life.
Yeah.
Yes.
Now, second question, sorry for that.
Yeah.
Now, okay, I'm on a regular medical medications
Yeah.
for diabetic and cholesterol and blood pressure.
Yeah.
What about the claim form? Is there any, is it necessary or is it essential to have a claim form every month when I take the medicines, or it can be on 6 monthly basis or annual basis? Because the prescription is the same, you see?
Yeah.
So that all the medicines that I take, it is for, I have to take every month,
Correct.
regular, in a daily basis.
Yeah. So, do you want to answer that?
Yeah,
or
let
should
me answer that. I have a presentation specifically dealing with chronic disease management
Okay.
and how we can utilize it better to manage the benefits.
Mhm.
So I'll take you through it, and maybe you can correlate with the points which I'll be making.
No, I've been in touch with Diana. So I just had 4 or 5 rounds of in medical, this pharmaceuticals of Good Life. So at that time it was not any registered or something like that. So I was, made run here and there. But finally I just got the registration done, but just I was asking her, what about the claim form? If doctor gave me the prescription and I am allowed to use the same claim form for every month or no?
No. So, standard practice is when they give you a prescription, local underwriters, correct me if I'm wrong, they can give you an extension up to 3 months of the prescription.
Yeah.
Right? They can give you 3 months of the prescription.
Yes.
When you go and refill that prescription,
Mm-hmm.
ideally, the standard process is there has to be a claim form attached.
Yeah.
Because the claim form is attached. The prescription can stay the same, but with a new date now. The doctor will stamp it, diabetes, so your medication for diabetes. After 3 months, it has to have a fresh claim form and fresh prescription.
After 3 months.
After 3 months.
Yes.
Now, what we do as Life Care, so please bear in mind that we are studying the group now. We've just come in now. We will understand your data, we'll understand your patterns.
Okay.
You will tell us, we will send the claim form to the doctor, they will fill it, sign it, send it to us with the same prescription, and then we will submit the claim on your behalf. So the administrative headache goes out of you, but you just need to communicate that my next prescription is coming on this time. And you must have a constant doctor that you go to, right?
Yeah.
So that same doctor, we will be on the panel, we'll communicate with them that uncle is coming for his next prescription. Please fill in the claim form. We'll take the claim form plus the prescription, get it authorized, and you get the medication.
So that doctor has to send a prescription form, a prescription and a claim form directly to the insurance company. We can't collect that.
You can,
You can with
but
the
to
stamp
make
and
it
all these
easier for you,
Yeah.
you can communicate to us and
Yeah.
we do that process for you,
Okay.
right? But you can get it. They can send it to UAP directly.
Okay.
They can send it to Life Care, which will eventually send it to UAP. So either way, the end point for that process is UAP.
All right. Thank
Makes sense?
you. Thank you.
Thank you. Still on the inpatient benefit limits, we are on the psychiatric and psychological illnesses with the changing technological times and also due to the nature of our changing environmental, there's a lot of cases whereby members could require maybe an admission into a psychiatric facility, then that is also covered with the limits being at 500,000 and 300,000 respectively. We also have a benefit for post-hospitalization treatment in the event that a member happened to undergo a procedure and they get discharged and they decide to recover in a place, at least maybe the coast region, and the facilities there is not under our panel, then they can go seek to be dressed. If there was some physiotherapy involved, then they can go, and then we will offer them on reimbursement basis. But if it is within a hospital, within our panel, then you can just run your smart cards. For congenital condition, that is also covered, but this is particular for young parents with babies. So for the organization, I doubt if it will be applicable. Non-accidental dental inpatient illnesses, that is also covered up to the tune of 300,000 and 200,000 respectively. And these are particular diseases which afflict the mouth. And the same applies to non-accidental ophthalmic inpatient illnesses. For example, the removal of cataracts, laser surgery, then it would fall under this particular category. For any accidental related dental and ophthalmic treatment, then that is covered up to the full inpatient limit depending with the category.
So I just want to slightly highlight on that point. The non-accidental and dental inpatient illness has to lead to a hospitalization. So in most cases, I think the diabetics would know that after some time, the diabetes can either hurt your gums or your vision. In certain instances, if that leads to a surgery, particularly, that's where the limit will come from.
COVID, yes.
Yeah.
For example, a cataract, do you need to be hospitalized for a cataract?
Sorry, is that I didn't get that.
You know, you talked about the dental,
Yes,
but for the ophthalmic side, where he said cataract falls under that category,
yes.
does that also mean hospitalized cataract? Because cataract is done outpatient. And what if you don't have an outpatient cover? Would you still cover?
So most of the times, even if you don't do a cataract on inpatient, you would have to do it under day case.
Yeah.
Oh,
It
so
would fall
it's
under day
considered
case, yeah.
Inpatient, but daycare.
Yeah, exactly. Because at some point you'll need to be under anesthesia and you'll occupy a bed. At some point during that procedure, so it will fall under day case. You can't.
Do such things require pre-approval or?
Best practice is to get it pre-approved. Yeah. Yeah. Ladies, any questions?
So yes, when I said I've got a further question, it's based on that cataract.
Yeah.
When you say your limit is 300,000, meaning that you will get paid for, because some of this, what do you call this, day hospitals require you to pay upfront. So it's not under the panel, you pay upfront.
Okay.
It means you have to pay in advance, and then you
Okay.
claim. Is that?
I'm going to answer that on your behalf, but if I'm wrong, please correct me.
Okay.
If you're on the panel, ideally you should not be paying a single shilling out of pocket.
Correct.
If you are not on the panel, there's normally two situations. One, if the doctor or the hospital agrees, UAP can issue something called a manual authorization, like a guarantee of payment, but that is subject to the hospital and the doctor.
And the doctor.
The other aspect is you pay and then you claim,
Okay.
right? But just to be very clear, they will only reimburse the same amount that they would have paid the same doctor within their panel.
Ah,
Okay? So
Okay.
let's say your private doctor charges 150.
correct.
The limit that UAP, as an example, have set for that treatment is 100,000. They will pay the 100,000 back to you.
Right. Right.
They will not
Okay,
pay the full
okay.
amount. Yeah.
Yeah, both. It could be both, yeah.
Yeah.
Yes.
Yeah.
So is it something that you disclose to the patient? So if you're going to a private hospital that is not in the panel, do you tell the patient that this is your limit?
Yes, we do. That's the standard practice so that the patient can be well informed to make a decision.
An informed decision.
Yes.
But uncle, this is on the
Not uncle.
okay, brother. This is on the premise that you tell us before you
Correct,
go in.
correct,
yeah? But
correct.
when you go in, do the surgery, then come out and tell us. If there's a surprise, then it might be complicated to handle it after. So always best practice is let us know that I'm going to doctor this one. We will tell you on the panel, yes, no. If it's not on the panel, we'll tell you this is your limit.
Okay. Because as I sort of agree with Brother Sajjad,
Yeah.
the last provider did not say the limit. It was a surprise, and they were informed well in advance that there is a patient going in,
Yeah.
and when it came to payment, they paid less.
Yeah. So it came as a surprise.
It came as a surprise to us. So I'm just saying, is that best practice from us as insurance, or is it just life case best practice?
It should be an insurance best practice,
practice.
and I think on your case it was a very unfortunate event. It should not have happened because based on the
Because-
correct information
Yeah.
which they all have shared, at least you could have make an informed decision on it.
Because ideally the process is, as soon as you call and tell them I'm going to this hospital, immediately they're supposed to tell you this is not on the panel.
Correct.
Immediately.
Correct.
Whether you call us or you call their helpline directly. Because we have the same information they have and that you have. So somebody should immediately tell you, look, this is not on the panel, you're going, but be advised that this is the limit.
Okay.
Then it's your choice.
Okay, thank you. I think we were on the COVID. COVID is also covered, and the applicable limit per family is 500,000, while for the overall group is 5 million. We also have a coverage for external medical supportive appliances, and this is where the wheelchairs, basically the crutches, come in. And in the event a member happens to be issued with one, then that will be covered subject on a leasing basis upon the member recovering, or if it's something which will be prolonged in their life, then that is also covered. We also have a cover for last expense as a value add, and this is basically in the unfortunate event that a member happened to pass on, then we at All Mutual will give the bereaving family up to a tune of 100,000 for them to give their loved one a befitting send-off. Yes. Group limit is for the whole community. Yes. No. It's only the COVID one. Yeah.
So if 10 people go, that's it.
Basically. But I think we have priced and done our calculation, so basically we have done our maths and know how to price it. Yes. Last expense cover benefit. Last expense is usually a benefit whereby if a member of the organization happen to pass on, then there's that sort of benefit at All Mutual, which we usually give the bereaving family in order for them just to give their loved one a befitting send-off. I know for the community, it could not be familiar like us, the Africans, where we have an elaborate kind of ceremony when it comes to giving our loved ones a send-off. Yeah. Okay.
But I can still take it. Even if I'm not, but I can still claim it.
Yes. Winding up the inpatient benefit limits, we also have the coverage for ambulance, as I had stated earlier, subject to pre-authorization. There's also passive war, terrorism, and political violence treatment. That is also covered up to the tune of 500,000. There's also a benefit for home nursing, and this is whereby maybe a doctor has recommended for a physiotherapist to come to your home and do the massages, or a nurse coming and check how you're progressing after a procedure, then that is also covered.
I feel like you should expand on that just a bit more.
Okay. I expand on the home nursing, yeah? So home nursing, as the name suggests, a member of the organization has been discharged from the hospital, and the doctor has recommended that they need a nurse to come and check on their progress, how they are doing. If there's any dressing of the wounds to be done, it's done. Basically just to check on the progress, depending with the recommendations from the doctor. Then that benefit is where it is applicable. It's usually subject to a condition, sub-limit, as it has been stated there. It could be a chronic condition. If it's a chronic condition, then the chronic limits will apply, the 2 million. If it's a pre-existing condition, then the pre-existing limits will apply.
Yeah.
Yes, yes.
So the doctor will need to write a report that the member does not need to be at hospital, but she needs a medically trained person to manage these wounds. Once we get that report, we send it to UAP. They normally standard authorize about 10 sessions. Then if there is an increase of that it's justified medically, they authorize another 10 sessions based on the limit. So the treating doctor will have to write the report. The pre-authorization will come from All Mutual. They normally give you a certain amount of sessions. And then if those are exhausted and the member is fine, then it stops there. If they're not exhausted and they need more, then the doctor just says, give them another 10 sessions. It has to be. So there are normally two options. One, they have their own nurses they will recommend, but you also have the choice to bring in your own nurse, and UAP will give a specific rate. That this is what we will pay that nurse for a specific day. No, but the rate will stay the same. Yeah, but it has to be qualified, a qualified nurse.
Yeah.
Yeah. Is an exclusion for everyone. Hmm? That's a conversation we'll have on the side.
And just maybe to clarify on the home nursing, is that you happen to be discharged from a hospital for it to apply.
Yeah. Next.
I don't know it has hand.
So while he's figuring out the flicker, any questions in between what we have shared so far? Great.
Okay, let us go towards the outpatient benefits. And again, we have two categories, but based on the population which we did, it's only members who are category A, which is 150,000 and 100,000. And under the outpatient limit, we have a benefit for medical checkups in the event that you need to see a doctor just to get your comprehensive body checks done. Then that will be the applicable limit of up to 15,000. Services which are covered under the medical checkups are not person-specific. They are person-specific based on their age, gender, and medical history. Also, depending with the reports shared by the doctor, who will recommend the kind of checkup to subject you to. We also have a benefit for pre-existing and chronic condition and illnesses, including HIV, cancer, and diabetic. That is also covered up to the full outpatient limit of 150 or 100,000 respectively. Vaccines, this one are specifically for babies, so for the organization or community, I think it won't be applicable. Okay. So basically, winding up the outpatient benefits, we also have a cover for supplements. And for supplements to be issued, there has to be a diagnosed condition, a doctor issuing a prescription on why you should get the supplement, then that will be issued. But over-the-counter medication or issuance of supplement, that is not covered. Again, just like as in inpatient, we also have external appliances. Maybe you have twisted your knee, your ankle, then that is also covered under the external appliances benefit. And still, COVID is also a benefit under the outpatient, and this is in particular for those minor cases which require over-the-counter medication or treatment, that is covered.
Next.
I think the members are aware that the scheme or the insurance cover has a copay, and these are the charges, particularly for outpatient admissions. If you visit any of those hospital facilities, then those will be the applicable charges before getting treated. Not yet. Yeah.
Yeah.
Yes.
So the copay is only applicable only on outpatient services.
Yes.
It says here there's a coverage here on consultations, specialist consultations. Is that an outpatient coverage or an inpatient coverage?
That's an outpatient coverage.
Okay, so if you go for, like, if you're hospitalized and you need a like a specialist consultation, then that will be covered under inpatient only if, obviously, you're inpatient, right?
Yes.
So basically, whenever someone is hospitalized, so most of the time the doctors will keep on coming, and they'll charge you for the consultations on those checkups. Yeah, so you'll come maybe during the day, in the morning. So that is an inpatient consultation. So that you won't be charged a copay on that. Yeah. Next.
We also have exclusions, and I think this is where members should at least acquaint themselves well with. But just to mention a few, for example, cosmetic surgery, that's an exclusion unless it's caused by an accident. Weight management treatment, that is also an exclusion, it's not covered. Participation in professional or hazardous sports, example, bungee jumping, paragliding, that is also an exclusion. So the list is long, but I think I'll be able to share this particular slide and also the policy document I've already shared with Sabir. So the members could at least acquaint themselves well with. Yes, it's possible. I'll share it through Sabir to share with the leadership. Yeah. Yes.
So we'll send out a flyer once we're done with today. We'll have all our contacts on what situation and their contacts also. So you'll have all the information that you need. I think just to point out on one of the exclusion which is important here, which is quite practical, is specialist fees unless referred by a general practitioner. So in that instances, you can't go to a specialist directly. You can't go to a cardiologist directly. You can't go to a nephrologist directly. A GP has to recommend you to go to that specialist. That's outpatient coverage, right? So that's normally a practical exclusion that we see quite a bit, because I don't see bungee jumping being a point of concern. I don't see any military or gang issues here. So I just want to make sure that we're very clear. And the other one that normally comes in is HIV. The other one then is also pandemics and epidemics. So COVID falls under that category. They made an exception. Depending on how, God forbid we never see a situation like that, but if another pandemic does come, ideally it's an exclusion, right? Unless it becomes a global thing and they say remove all exclusions. That's another thing that to keep in mind. Diagnostic equipment. That's an exclusion. Glucometers, exclusion, right? So they are on the exclusions. What we will do is, when we are sending this, we will leave out the ones which we know are general exclusions, but we will highlight the ones which we feel might be a practical thing you should be aware of to be an exclusion. Does that make sense? Yeah.
Maybe to add on, any expense that is recoverable from any other insurance, like SHA. I know it's not working, but whenever you're hospitalized, for the bed expenses, they normally pay net off net off because it's something that you're required to have by the government.
I don't see dialysis. Where does that fall under? If you have to go for regular dialysis, kidney dialysis?
It falls under the chronic,
Yeah.
ideally. But if you can do it on outpatient, then it's within the outpatient limit. Correct?
Yes, correct.
Then you don't. Yeah, unless you're hospitalized.
Yeah.
That's a 3-hour session.
Yeah.
Would it fall under outpatient or daycare?
It can fall under outpatient. So, daycare by definition is you have to occupy a hospital bed. Dialysis in most instances you don't occupy a hospital bed. It's like chemo, right? You're in the hospital on outpatient for a specific amount of hours, but doesn't mean you're hospitalized. So it falls under outpatient, but there is situations where you require dialysis on inpatient if your condition is severe enough. So it depends on the situation at the time.
The net of SHA, but you also mentioned earlier in your slide that you're covering people across a particular region. So what happens if somebody is hospitalized, say in Tanzania? Is there another, you still calculate with local SHA or you calculate with the local Tanzanian coverage, or I don't know, how does that work?
So we normally, to answer your question very simply, sir, is we normally follow the rules of the land. So if there is no SHA, they give you the 18K or the equivalent in Tanzanian shillings. If it's applicable in the country, then they apply it. So it depends on the rules of the land in the country. Yes.
If you are admitted in Tanzania, then if it is not being charged, then it won't be paid. You won't be able to pay that SHA shift.
So let me understand your question. You're saying as a Kenyan citizen admitted in Tanzania, then it doesn't apply. Yeah. So it won't apply to you because your hospitalization would be based on emergency or an accident. So it won't apply to you. Yeah.
But what about those patients because we have many members in Dar es Salaam, they have NHIF kind of thing.
Yeah.
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 So how is it collaborated with your insurance?
Yes, it is.
Yes. So it's normally collaborated at the point of the hospital. Okay. Yeah. So like.
They are paying, they can show that they have been paying for.
Yes. Yes. So like you get an NHIF number, yeah? So when like here you get hospitalized, they tell you this is your bed limit. Exactly. Yeah.
And it's normally a contract between the insurance company and the hospitals, because the hospitals are in the panel. So the insurance company tells the hospital, we are not going to pay this much because you can collect that much from the government. Yes. Yeah, yes.
So on the same note, if you're traveling out of the country, do we have to inform you?
Most definitely.
So if we are traveling, we have to say, we're going to this location.
Yeah, yeah. In case of any eventualities while you're outside the country, when it comes to organizing treatment in that particular country, we will be better placed to advise on which facility, and also maybe have some sort of credit arrangements with the hospital if we know prior you had traveled.
And if you're not going to those countries that you are covered in, like the East African region, basically, then what happens?
That is countries outside the East African
Yes.
regions. What usually happens is that if you are in those countries for a period of up to 6 months, then we will cover you on reimbursement basis, whereby you will seek treatment, have those receipts submitted to us, and then we'll reimburse you on such.
But we have to inform you.
Yes, yes. 6 months, yeah.
It says 6 weeks.
Okay, maybe I'll have a review and share.
Okay.
Yeah.
So is it advisable for anybody who is traveling to get the travel certificate, like, you know, the insurance certificate that we requested for one of our members?
Yeah, it is.
Better to have that certificate while you're traveling outside the East African region.
Yeah, it is very vital you have that particular letter. It can be used as an assurance when you are admitted at a hospital that you are covered, and the bills we will be able to undertake. Yeah, it's just sort of an assurance to the admitting hospital in case there's an emergency admission. Yeah. Yeah, it will be on a reimbursement.
You have to pay first and then you'll be getting the receipts and then.
Exactly.
So if it's more than 6 months, then it will not be covered. But if it's anything less than 6 months,
Yeah, so from 0 to 6 months, you're still under their cover.
Consider increasing our bed limit. Why I say so? Because you mentioned a private bed of 18,000. I don't think so. Most of these hospitals are giving a private bed at 18,000 anymore. 18,000 qualifies you for a general ward. And recently I've experienced that when you go and their general ward is 12,000, for example, and their private is 20,000. The excess is not the problem. The problem is when they don't have space, they can't upgrade you. They can only downgrade you. Can we have you look into increasing our limit on bed? Just a consideration now, probably. Because I remember they wanted me to pay 47,000 for Princess Zara because they didn't have any bed available. So when I went there and asked them that my insurance is approving up to this much amount, and what you have is way less than my amount, approved amount, and what you have available on the upper side is 47,000. So they said we can only downgrade you but not upgrade you. I would consider in the range of 25 to 28,000 at least minimum. So that covers at least. This is I'm talking. I don't know about others, but most of these hospitals, 18,000 is nowhere close to covering us, unless you change the terminology and say you are entitled to a general bed ward, because that is what the price can entitle you to. Please don't tell me you'll have to increase our premium.
Yeah, it's a very valid point, but again, to just clarify, you might, when you walk in as an individual, you might be asked to pay the 40,000 or 30,000, but from an insurance perspective, when they tell you it's a private bed, for them they have the numbers, and that's why now they have assured the hospital they are going to give them the numbers.
So this is based on contractual.
Yeah, it's more of contractual. So it might be 18, yes, but again, like you've said, it's good to clarify and make sure if it's a private bed, is it a private bed with a standard bathroom or a private bathroom? It's good just to clarify.
I think we can go to the processes now.
Next. Yeah, our inpatient admission is usually straightforward. If it's a scheduled admission, then it is proper you notify us 48 hours prior to the admission, just for us to make a better preparation and arrangements with the admitting hospital for them to have a better view of how to treat you. But in the event of emergency admission, treatment usually starts right away, and the hospital notifies us within 24 hours that we have your member in our facility, and then we'll be able to take over from there. Always make sure that your SHIF or SHA records are updated, because the billings will be net of SHA. And also have your either physical card or your virtual cards, at least number memorized, because that will be the point of reference when it comes to seeking authorization from the point of admission. Admission is usually straightforward, whereby we issue a letter of undertaking to the admitting hospital, granting them authorization to continue with the treatment, subject to the cover limits which I had mentioned prior. In the event of claim settlement, that is usually between the hospital and us at Old Mutual. You, the member, won't be inconvenienced unless it is a reimbursement case. Next.
Yeah.
Yes.
We're just waiting to finalize everything regarding the onboarding, then we'll send out physical cards.
Outpatient, I think most of the members have interacted, those who have, and the process is usually direct and straightforward. There is that form which I think Uncle had mentioned, whereby you need to fill. There's a part where the member will sign, and also a part where the doctor has to sign, stamp, and verify. When it comes to the point of discharge, your smart card will be run, and the member will use their fingerprint to close that particular bill. For pre-authorization, any drugs above the 10,000 limit must be authorized by our care management team, either by email or phone. And I think this is where Sabir and myself number will come in hand in the event that there is some delay or challenges in that. Examinations like CT scan and MRI scans, that also must be pre-authorized from our end. And in the event, because we are in the technological era or times, and these are prone to downtime changes, or whereby the network is off, then we have a manual way of settling those particular claims, which we call the off-smart, and it has to be authorized by the hospital, necessitating for us to proceed the off-smart way.
Now, sorry, while we are there, I want to emphasize on one key point. Ideally, the process is you walk into the hospital, you have your smart card, you give it to the admissions team, they do what they need to do from a system back-end point of view, they get the authorization. They might come back and ask for information, the reason for the authorization, and everything. I want us to set up a standard practice so we are very clear. 0 to 30 minutes, if there is no action that has been done or a member is still at the hospital, immediately call the life care number, right? You need to give them an allowance of 0 to 30 minutes. Of course, this is excluding a life and death emergency. We don't wait 30 minutes in a life and death emergency. But as a process or as a standard practice, 0 to 30 minutes, the admissions team writes to the UAP, tell them this is the course of treatment, this is what has been prescribed, please authorize. It takes time to get that process rolling and give them the authorization. But my urge to the community is don't wait 4 hours or 5 hours to call life care. Don't let it get to that point of frustration, because by then you're already angry. I don't know you at the hospital, right? So when you call me, I become then the punching bag, right? So my request humbly is, in 30 minutes, you're at the hospital, nothing has happened, immediately call life care. We then know what we need to do to fast track the process for you.
Next.
Please, Uncle.
You say, you mentioned that at the discharge, we have to take the fingerprint or thumb, correct?
Yes, correct.
But now, sometimes our thumbprints and fingerprints don't work. I mean, look, it's at the edge, and even at the immigrations, when they look at the edge, they say, you're a senior citizen, you don't need to.
Have a thumbprint.
Yes. So, surely, I
Okay.
guess such scenario can occur.
So, okay. I don't want to lie, I've never dealt with such a scenario that the fingerprint itself doesn't work. The machine doesn't work. So when you guys put your fingerprint, it doesn't read.
It has happened to
All
me
5
as well.
fingers.
Yes.
All 5 fingers.
Yes.
Is it?
Yeah, just maybe to answer Uncle, yeah, we have experienced such
All right.
on our end.
Yeah.
And in this event, we usually trigger
OTP.
the OTP method.
Yeah.
Yes, we send an SMS with the code, and then you give them to close that particular bill. Yeah.
Otherwise, we will be standing there for hours.
Yeah. Yeah.
Exactly.
Yeah.
Yeah.
Yeah. So no, the cards are definitely going to come. They're not going to be smart cards. Yeah. Are they going to be smart cards?
No, not smart cards.
Yeah. So they're going to be cards with your membership numbers and your information. Yeah.
Yeah.
But your print will still be there. If it doesn't work, then they trigger the OTP to the number. Now, just while we're on that point, two things I wanted to elaborate is the clinic or the pharmacy, wherever you go, cannot issue instructions on your behalf. If you want a registration of a number done, the email has to come from you directly as a member. It can't come from the hospital. Change the number on the smart team or smart access to this number at that point, because it's normally a 24 or 48-hour process. It's registered on a system. The other thing is sometimes these things have a downtime. And again, when they have a downtime, you just immediately call us. We also as LifeCare have relationships with these hospitals. We can then tell them proceed. We're sorting it out from a system or from a manual point of view.
Sorry,
Yeah.
you gave us an option of calling you while we are at meeting.
Yes.
0 to 30.
Yeah.
Can the same service be offered when we are discharging, because it's taking a whole day to discharge? And when you go back to the hospital administration,
Yeah.
they always give us one. It's a song they sing, waiting for insurance approval.
So to be honest, uncle, uncle or bro? Bro, okay. 5 out of 10 times, they normally have not sent that information to the underwriter, okay? Because they have a backlog that they need to catch up on. So they say they've sent it, they're waiting for insurance. You see, for us, we want to get you out as quickly as we can because it costs us less when you're not there, right? So our objective is to process that quickly. So yes, but discharge is a different process than admission. Admission is life and death. Discharge is you're stable and they need to take you out. So what normally happens is they need to consolidate pharmacy, doctors, diagnostics, and give one bill. So as much as we might be ready to speed it up, maybe the full bill has not been accumulated. So standard practice on discharge is if you know you're being discharged that same day, call us in the morning. We start doing what we need to do, and then we also push the hospitals directly. We also call the hospitals directly because we understand that sometimes you're alone in the hospital, right? So we push the hospital directly. So discharge works a bit different. So if you know that evening or that day you're being discharged, just let us know by morning, we start working on it. If we need to give a guarantee of payment from our side, we give the GOP, then the hospital consolidates what they need to consolidate and finish. Make sense, Dennis?
Yeah, very much.
Okay.
Next. Maybe I should touch on this reimbursement basis, and these are the particular customary rates which Sabir had mentioned earlier. When it comes to a general practitioner, we will reimburse up to 3,000, and for a specialist, it's 4,000. Again, subject to our reasonable and customary rates as determined by the company. The claims must be submitted within 60 days from the point of service or from the date of service for you to be reimbursed. So for inpatient, we'll need a duly filled inpatient claim form, a discharge summary, at least validating the period which you are admitted up to the point of discharge, and the bills should be itemized. It's also quite vital for the members to be aware that the receipts to be issued by the hospital or admitting hospital should be ETIMS compliant.
Yeah, so this is also another point I'd like to add. Please, if you have a manual claim form or a hard copy claim form or a soft copy claim form, please first send it to us. Don't send it to UAP directly. The reason for that is, if you send it to UAP directly, it takes time for us to be notified that you've submitted a manual claim. If there's any information missing on that claim, they will reject it because it's system operated. By the time they communicate the rejection to you, it's normally a week or 8 days have passed. So you've lost that time. So my kind request is, when you have a claim, hard copy, soft copy, a manual claim that you need submitted, send it to us. We will vet it immediately. We will tell you this will delay because we need X, Y, and Z as information. We will follow it up for you, and then we will keep you updated on the progress. But if you send it to them, it takes time till they communicate that they are missing information. I agree. I'm not arguing at all. But that's the prices that all of the ones on the panel.
Yeah.
Remember one thing. Sorry, auntie or sister? Sister, okay. Remember one thing. These guys give thousands of lives. So what the consultant will charge you is not what they will charge them. So they've already have these contracts at the back end, right? So that consultant, if he's on the panel, just tell them charge UAP directly. Yeah. No, no. I know. It's not fair. Unfortunately, that is based on contract negotiation, right? So, standard process. See, I have a tendency to want to say yes to everything, but unfortunately, I can't. Yeah, it would be ideal, yeah. So we can do that for you with a pharmacy. We have contracts with pharmacies. So you can tell us and we can get you a very good rate with medication, even if you're not an outpatient, and then you pay them directly. But with doctors, it doesn't work that way. Yeah.
Okay. Sorry. There's a question.
Yeah.
Repeat the question.
If
Thank you for that question. We have a manual way of generating the ETIMS receipt, and in the event our facility is not, then we'll share with you that process where you can generate it yourself. We'll give you our PIN. You go to your eCitizen on your KRA, do the application, and be able to self-generate it. If it's not ETIMS compliant, that It just has to be, unless now we go the self-generation way, where you have to now self-generate the e-teams. What you'll require from the pharmacy is maybe their PIN and our PIN, then you can. Yeah, it's fine. It's okay with it. Yeah. Exactly. Yeah.
Okay, sorry.
For reimbursement, if a patient has been hospitalized and she wants to be treated by her own doctor who is not on the panel, I know we have had a case, so that's why I'm asking. This patient, she had an agreement with the doctor that it would be reimbursed because he was not on the panel. Doctor refused to, have a direct billing with the hospital, although the hospital was under the panel. Now, her question is, does she have to pay the doctor to get reimbursed? What if she cannot pay and, send the hospital receipts to the mutual to get reimbursed? Pay directly to the doctor. Can it work?
No, unfortunately, that cannot work. Yeah.
She has to pay first.
Yeah, she has to pay, get the receipts in order to forward it to us. We verify and then reimburse. Yeah.
Okay, I had a small question about reimbursements. Usually, sometimes we go for further treatment outside the country, probably India. And when we come back with the bills, the terminology is what we are used to, or what you are used to expecting in an hospital bill is not the terminology they use there. So I'm asking for a specific reason because I had a bill of whatever amount, and there was an item in the bill which was mentioned miscellaneous or something like that, which was like $1,000 and the insurance refused. This is not somewhere I can, it's not Aga Khan Hospital I can call and get a clarification again. This is a hospital in India I have already paid for, and I've got an itemized bill. But when I come to you, you do not agree with some because the terminology is what you are used to is not what they use in Indian hospitals. So how will we go about such a scenario? Because it already happened to me once. So I would like to know what can we make it that it doesn't happen again? What can I do right this time around?
Ideally, I've not experienced treatment in India, so I wouldn't really know. But ideally, there shouldn't be anything on your bill indicating miscellaneous. Ideally, right? They should be either sanitary, like Aga Khan, they charge gloves, they charge injections. There's normally a name for it. I forget what it's called. Yeah, consumables. So there should be an explanation. And in the instance it doesn't happen, it's always good to have a contact from the hospital or the doctor in India where we can write to them and get that clarification. Because to answer you very honestly, they will never pay something indicating miscellaneous. They will not pay. There has to be a description behind it, or sometimes if it explains that it's for equipment or gloves or something like that, and the doctor sometimes just writes this is what it was for, then they pay. But other than that, they don't normally pay if they don't understand what the charge is for. That's how they would treat it. Yeah.
So something that Sajjad has mentioned, does your cover expenses for treatment outside the country? For example, a knee replacement may be cheaper in India than it is here. So would you cover that if somebody goes to India or anywhere else for that matter?
For overseas treatment, we cover treatment, as you had mentioned, in India. Western countries is an exclusion because of the cost implication, which does not match with the premium being paid. But for facilities in India, we have credit facilities where you could also just get your bills run depending with the hospital or on reimbursement basis. So yeah, that's
No, I
policy.
think his question is the knee replacement, correct me if I'm wrong, his question is if the knee replacement can be done here, but he personally chooses to go to India because it's cheaper there. will UAP pay that bill when he comes back and reimburses it? It's a choice. It's not a lack of availability of treatment.
Mhm.
It's a choice. Him. Yeah. So, no. Air tickets, evacuation is not included. So air tickets, no. Yeah.
Yeah. Yeah.
Just the hospital.
Ideally, if it's a local treatment can be done within the country, it's usually reviewed on a case-by-case basis to make that particular decision. But we have never denied anyone who's seeking treatment outside the country, depending with the cost. Yeah.
Mention something that you have a contract or you have a relationship with hospitals outside the country. So on what basis is this relationship?
Credit, direct settlement. So, if I understood you correctly, you wanted to know the nature of the relationship of UAP and the hospitals outside of the country. So, let's take India as an example. Very, very few hospitals in India, depending on where in India, offer credit services to an insurance. He's saying that in that instance that happens, UAP can give a guarantee of payment directly to that specific hospital on the parameter that they accept insurance.
Okay. Yeah. But for what kind of treatment? Treatment that is not available locally.
He's saying that they will not deny you even if it is available locally,
Yeah.
right? But obviously the preference would be to treat it locally, right? But they would not deny you if you wanted to say, look, it's my personal choice. I'm going to India, I'm going to do the knee replacement, I'll pay for my fare, whatever it is, the accommodation. They will pay the equivalent of what it would have charged here.
Yeah.
Is that correct?
Yeah, very correct. Next. 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 I think I had mentioned on the chronic disease management program, particular for members with those particular ailments. We know when it comes to chronic disease, it's usually management to at least have the benefits not exhausted before the policy ends. And we at Old Mutual were very keen on this. This is basically what we are championing, to have the members registered with in our database for us to be able to journey with them when it comes to this particular management of the ailments. We have the 3 key pillars, with the first one being health promotion and patient support. And this is whereby members will be able to get educated through monthly webinars. There's also newsletters which we share, and also organize quarterly wellness schedules for physical and virtual corporate health talks. And what I mean by this is that we can just organize for some of the specialists to come in the community, do a basic setup or a checkup for the members, for them at least to know where they are when it comes to their physical well-being. There's also the second pillar, early detection and screening of non-communicable diseases. In the event that something is picked while during those particular checkup, then it will be easy to manage throughout the cycle of your insurance cover period. And the third aspect is the enrollment into the health navigation, whereby now we journey with you throughout the whole process of having your disease managed. Next. 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 Maybe on the telemedicine, this is for particular members who have their outpatient benefits. You could consult a doctor virtually in the event that you don't have a major disease which require hospital visitation. We have those particular applications on the shown below the screen. and you could be able to reach out to a doctor, set up an appointment, either through Zoom, through WhatsApp, and they'll be able to issue a prescription and have the medicine delivered wherever you will be. And the thing with telemedicine is that it has eliminated that geographical barrier whereby you could be in Mombasa and have the medicine delivered directly within 48 hours to wherever you will be. It is convenient and time saving, whereby having, rather than you spending almost half of the day at the hospital facility, you could just within a 1 hour period set up an appointment, get your diagnosis and being prescribed the drugs. Next.
So HealthX is one of the life care companies. So this will be enrolled slowly, but later for free. So we're going to program all the members on the scheme, but it'll come slowly. I don't see you guys using it, but I will still program it. But it means you can just access a doctor by your phone anytime, 24/7. It's your decision. So I just wanted to make that point. Sister, ideally, if you're inpatient, you should be in the hospital, no? But this is, yes, you can use it at any point in time, weekend, anytime. But it's basically you want to talk to a doctor, just I'm having a cold, I'm not feeling well. So this gives you an outpatient, but up to the limit of consultation, and it's free for you guys. So that's it.
I think that's wonderful, Sabir. I didn't know HealthX is part of your life care family, but if you can avoid it for all the members, then it will be a game changer. Next. Telemedicine also goes hand in hand with the telecounseling, whereby in the event that you need to reach out to a psychologist or a counselor, then that is also covered for the members with the outpatient services. You could just do a virtual setup, organize, and at least get your mental health check done. Pharmacy First is also another one of our value adds for our corporate clients, and this is basically for minor health concerns. For example, common colds, sore throat, skin rash, mild cough, heartburn, or diarrhea. You could just go to any pharmacy within our panel and show them, or rather tell them the symptoms, and they will be able to issue you with a prescription rather than you going to the hospital for such minor ailments. This is also a bit beneficial when it comes to your benefits, because it kind of eliminates the consultation barrier, whereby you'll have to pay consultation fee to a doctor. In a pharmacy, you'll find that it is usually subsidized, ranging from 200 up to 1,000, for you to at least save on that particular cost. Next. Winding up this presentation, we usually have a wellness calendar of events, and it's usually thematic depending with the month. For example, January is whereby people usually set up their resolution, and we at Old Mutual, we decide to partner with our members to at least have an accountability partner. For example, if it was to do with watching your weight, quitting some of the harmful habits, for example, smoking, then we will be able to at least set up a program to journey with you throughout the year. February, at least we did email us to do with a thriving lifestyle. And the list goes on and on. For example, now that we are in May, we are focusing majorly on the mental health awareness and also hypertension. So a lot of our education is basically centered towards those two particular topics. And we have specialists depending with the requirement. The organization, maybe through Life Care, they could maybe decide that they want an online seminar with a specialist. Then we'll be able to conduct such. at least for the members to feel value for the premiums which they are paying. So basically, this marks the end of my presentation, and I'll hand it over to Sabir, and in case for Q&A. Usually, we have an email database whereby maybe through the leadership of the organization, once we get the mails, then they can be shared directly to the members. But if they are specific on some certain aspects which they want education on, then that will be a request coming from the community. Yes, they're offered online or physical, depending. Yeah, at no extra cost.
Oh, we'll charge a little bit. No, but to make it simple, what we'll do is we'll share the links to the community reps, then they can share the links with you. And these normally are recorded. So as long as it circulates along the community, even if you can't join at the time, you can watch it later, basically.
Regarding your pharmacies, we find them, and I think one of our members is there who was struggling with Ifa. The pharmacy bills, I mean, the medicines are more expensive than the local, wherever they're buying it from. So, you know, as an outpatient, these units would be utilized, you know, faster. Is there any way that you guys have some pharmacies which have, you know, the prices are better?
So first, Mr. Iqbal, you can give us the contact for the pharmacy, and we can speak to All Mutual to put them on the panel, so they bill them directly. 2 is you can pay, and then they claim. Okay, so we can register them. We can get them to be put on, correct?
Yeah, correct.
We can get them to be put on the contract, and then they pay them directly. It'll take about a month, but it can be done. Yes, so they can give good discount, and All Mutual gives them more business.
Yeah, even hospitals and doctors whom the members feel they are qualified, they have enjoyed good service, you can always put a request to us to have them onboarded into your panel.
So Corner Pharmacy and Renchem. Yeah.
Yes, yeah. Yes, exactly. We have a list.
We've already shared that. Yeah, we've shared it here.
Yeah. So thank you. If there's no further question, I'll hand it over to Sabir, but it has been informative.
Yeah.
Very interactive, and I've learned a lot. There's a lot of take home, and I look forward for more future interactions. Thank you.
Good. So just to wind it up, we have a value add program we'll be rolling out, but now we're stabilizing the scheme, so you'll see a bit more of me in the next few months. But other than that, I think if there are any further questions, now would be the chance to ask about life care, about what we can do, about the product, the underwriter, anything you want to know, and we'll be more than happy to help. Yeah? Great, yes. Thank you.
On behalf of SAJ, we would welcome you. You have taken on our policy. Thank you for coming. We appreciate the support. And as you've seen, we've got very many interactive members. This is not all. This is just, I would say, maybe about 10, 20% of all the members. We've got more joining, but your support and assistance will be the game changer here. So to the members, he's told you openly, please call them whenever you need them, even if you don't. We will be circulating. You'll send us the, so yeah, takeaway points. You'll give us the contact lists, this presentation. You have already shared the panel, so we'll put that all in one and send it over to all the members that are enrolled, and to other members who want to enroll. Yes. Yes.
By end of May, in the next week, 2 weeks, you should expect the cards. Because ideally now we're not expecting any more changes on plans and everything, so we've concretized on the list. So now it's about printing the cards and getting them ready. So by end of May, the cards should be with you. Yeah. So basically, right now you should be, the members of the scheme should be registered on SMART. So they just need to log in and activate the policy. Because the membership numbers right now have already been generated.
So let me get this straight. There's a link that has not been circulated as yet. You guys, we were waiting for the upload to all happen,
Yeah.
and then we share that out. So let's take another point that we'll send out the link for the smart access as well.
Maybe on the smart access, this is open to every member. Once you have the membership number, you can just go to Google Play Store, download the smart app, and onboard. I'll share the manual way of onboarding in case a member doesn't get the link. And it's usually straightforward. In the event there's any challenges, I'll share my number. I'll be able to guide you through.
Just to confirm, messages have gone out with the registration numbers?
Yes, unless there's a member who hasn't received, then you can share. You can share the numbers. We will.
Your membership number stays the same.
Yeah.
Just to remind you, our underwriter has stayed the same. Old Mutual has stayed the same. So their database remains the same.
Yeah.
So that's the swift movement that we've had. It's just the broker Lifecare has come on board to manage the policy for us. Will not
Yeah,
receive
they will
the
not receive
message.
the message. Yeah.
Right? So just if you have a challenge, as I said, try downloading the app. If you have a challenge, then let us know. We'll come in, or you can call them directly and they may be able to assist you on phone immediately and sort it out. There's some tea and snacks outside.